Hi, my name is Rebecca Seagraves, and this is the talk that I've been waiting for probably over a year and a half. Occupational therapy in the hospital after birth, but specifically after C-section. Welcome to Pelvic Health Nation on Pelvic Health Network. I'm with Royce Porter. Royce, how are you?
Doing great this evening. Thank you.
So tell me a little bit. We were talking a little bit offline, and I have to say, probably when you texted me, you messaged me a year ago, I was excited then about a male therapist treating women in the hospital after birth. How did you get into this work?
Well, I don't know. I just go all over the place when I'm working out here. So I'm in a rural hospital in Utah, and we've always talked about how we've wanted to work with the female population after birth and to provide care for them, but we've never had a female therapist to head that on. We've interviewed a bunch, but none have ever accepted jobs to work out here. So I decided to start working with it. I made friends with one of our OBGYNs out here and started talking to him about it, and he was on board with it. So then I just started taking classes and getting into it and asking more questions and keep getting more into it.
Okay, so Royce, let's back up a little. Okay,
Yeah.
so this was about how long ago that you saw a need and then you decided, okay, if there's no female therapist able to fulfill this need, treating women specifically in the hospital. Are we on the same page as that?
Yeah. So it started for me about a couple of years ago. We've always had it in the background. I love just improving access to healthcare for different areas, especially in rural areas. We don't have to travel 2 to 3 hours to get such healthcare. Um, but I was interested in it, and then I was down at the AOTA conference in San Antonio and wanted to take some of the courses. Wasn't able to because of some overlap of other things I was studying at the time, but I was able to rewatch them when I came back. And I reached out to, I think her name's Kimberly at USC, and she put me in contact with different courses. And then I went through Lindsay Vestal's classes, which then put me in contact with you and just others as well. So been going at studying it for about 2 years now.
So, Royce, you're a therapist of about 9 or 10 years, is that right?
Correct.
And so, what other settings have you practiced in?
I was initially hired in to do med surge, school based, and home health, and then to help out the skilled nursing if there was extra time after all that. So that's where I started. I grew school based practice enough that they were able to hire their own therapist. So I stepped out of there. Then I was able to grow home health enough that they were able to hire their own full time therapist. So I stepped out of there. And now I'm primarily working part time acute and then part time outpatient. So that's my.
So, so med surge, what kind of cases would you see on med surge?
Um, right now, a lot of the joint replacements we'll see people spending the night because they're weak, and pneumonias and small bowel obstructions, just falls, just kind of your general needed to stay the night in the hospital.
Right, right. A lot of people don't know this, and Royce, I'm not sure if you're familiar with this either. But with military hospitals, it's not unusual for male therapists to treat women in the hospital after birth. So, our military facilities, we see a lot more of that. Civilian hospitals, which is basically most of the maternity hospitals that we're talking about, at least in the United States, it's really rare, first of all, to offer even acute care occupational therapy. I have more therapy programs starting up that are physical therapy led.
Hmm.
It's even more rare to see a male therapist offering these services. So you were fulfilling a need because there weren't a lot of female therapists, but what got you thinking about inpatient care?
Um, probably the connection that I had with that OBGYN. I just that's where I could see a need, and I wanted to grow the outpatient side of it, but I couldn't start that unless I was working with moms right after birth. And so that's where the first desire came from. I was able to get in, and currently I have in his postpartum order set for every vaginal and C-section birth. As soon as he puts this set in, my order pops up, and so I see those moms the day after. So, and then I've been able to work with them and talk with them and educate kind of what the next few weeks look like. And I have a standing order for any mom that wants to come in and do some follow-up therapy with me as early as 4 weeks, and they can come in and do some therapy with me. And I just message his nurse, she puts an order in, and then our receptionist give them a call and they come on in. So,
Okay, Royce, wait, let's back up a little bit.
okay,
OBGYN, you have a relationship, male OBGYN.
correct.
How did that happen?
We built a new facility for our therapy and gym for the community, and he was on the board to kind of help decide what went into it. And one of my we call occupations is pickleball, and he was advocating against it because he wanted more strength training. So I invited him to come play and got him hooked. And so we just have played a lot of pickleball, done some pickleball tournaments, and we also do disc golf together, and that's where that relationship started. So
Okay, so this is a funny side story. I have to share this. I was a little judgmental about pickleball. I'll be honest with you. Like it was the last sport I thought I would get my ass delivered to me on a platter. And I think it was just like the slowness of or the ease of just how people were able to hit the ball, and I was like running like Serena Williams across the court. I was just like failing
yeah,
and sweating and dripping in sweat. I love pickleball now. So here's this OBGYN on the board for a school, right? To build a new.
this is for the hospital. We
This
just
is for the
I mean, more for
hospital.
like a focus group to kind of figure out what we wanted to put in our new gym.
What? Why did I catch school? Nothing to do with school. Nothing
No,
to do with the community or anything like that. So hospital, but
yep,
yet you were advocating for pickleball, the hospital for hospital employees. Is that right?
correct. Yeah, to
And
have
he's
we were
like,
building a new
no.
gym. Yep,
And so you invite him to play. That's kind of instead of just being at odds, you invite him to play
yep,
and then grow a relationship from there. I mean, that's the best kind of marketing. I mean, you can't teach that, Royce. You can't teach
yeah.
that.
That's the fun part. So now I play with him 2 to 3 times a week in the mornings.
Okay. So you make friends with a male OBGYN. How is a conversation? And at this point, do you want to get orders or are you just like, no, I really want this pickleball court? Are you thinking orders after C-section? Are you thinking women's health? Or are you thinking like, one project at a time? How does that relationship start?
Yeah, I wasn't thinking women's health at all back then. I started pickleball out here in our community. I'm a former tennis player as well, so I just wanted more access to stuff. I'm also on the city's committee to increase access to sports and recreation. So I've helped start and grow disc golf and pickleball out here. And just I was inviting anyone and everyone I could to come play. And I heard that he had a ping pong background, so just I had other interests at heart at the time, and then this kind of grew beyond that. So we had different talks on the pickleball court about what he was doing, and I kind of floated some ideas of stuff that I've heard, and which encouraged me to go study some more, and that's where it kept flourishing.
What kind of conversation? I mean, would you share like even just one with women's health? You hadn't gone to a conference yet at this point, right? Royce, about or
Yeah.
taking courses that you mentioned before.
No, just natural things. I mean, I have that introverted blue personality where I don't like small talk, so I just jump right into stuff. I don't waste my time too much with small talk. Except for on the med surge where you have to have small talk, so I have memorized conversations that I use. But I just ask him point blank questions. I mean, even this morning, I was asking him, which is a new thing about hysterectomies, how I now have a standing order to work with all hysterectomies of his. It's just like I've been reading about this, and what do you want to do about it? And he says, "Sure, that sounds great. Let's get it going." So I don't know.
Now, are
I
you
just
saying okay? So let me back up here again. Standing order for vaginal deliveries,
Yep,
standing order for C-sections,
correct.
and standing orders for hysterectomy, all to
Yes,
receive occupational therapy in the hospital. So that's within 24 to 48 hours before they
yes,
go home.
correct.
Okay. And not physical therapy, but occupational therapy specifically. Is that right?
Correct. Yes, just how our hospital's set up, it's worked better that way.
Do you have physical therapists that have expressed interest in providing PT services for this population? Any of the populations we're talking about?
So I'm on a team. There's 5 physical therapists, and then just me. We have one physical therapist who has expressed a little bit of interest, but still a little hesitant, and the others not any interest at all.
Male or female? I have to ask.
They're all male.
You have a whole team of male therapists.
Yeah, like I said, we've interviewed a bunch of female therapists, but none of them have ever taken the job, any job.
Royce, you're a father, is that right?
That's correct. Yep.
Yeah. If and again, this is completely up to you, but did you firsthand experience any challenges uh, during, pregnancy? Not you personally, but your significant other, after delivery, anything like that that you were able to see up hand and close and personal.
Um, our last one was a little traumatic. We went from starting out with our plan A and our birth plan to then learning came in 3 weeks early. He was breech. We didn't know. So we started preparing for a C-section, but then he came out butt first, folded in half, and that went pretty fast. So I wasn't even interested back then. But what really made a difference, so I was at the University of Utah when we had our first kid, and my wife had our first daughter with a certified nurse midwife in a hospital, and she really enjoyed that approach. So when we moved out and we didn't have access to a female birthing provider or a certified nurse midwife anymore, that really changed her birthing experience for her. And just kind of see what we had access to in the city that we didn't have access out here. I mean, with our insurance, we had access to many prenatal classes. Out here, there's one where they jam pack a lot of information into one class, but not much practicum in that class. And I saw how much, different counter pressures and birthing positions really helped my wife during an unmedicated delivery that it was hard for her especially, with coming out here, having to use the only alternative there was.
And what was the alternative?
Just with an OBGYN and
Yeah.
just not really encouraging of alternate birthing positions and being able to labor without an IV and just other things that were a little more accepted when we were in the city.
Did you, I mean, you probably have had this conversation a long time ago, but did you try to advocate to not have an IV or not have certain interventions done around that time?
Yes, and we were successful with it, just a little bit resistance, but we were able to. Our second one, which was out here, was uncomplicated, no IV. She drank her water, she stayed hydrated, and went well. And then the third one, we got the IV when we started thinking we needed to do a C-section because it was starting to turn into an emergency situation. But she was able to complete the birth and do it well. And it was, so yeah, we also hired doula services at the time to kind of help mitigate that lack of a certified nurse midwife for us. And as the partner in this, having a doula helped me immensely.
In what way?
Just the physical and emotional support. The running joke for us is when we have our first baby picture, a lot of people on social media were saying, "Why does Royce look more tired than you, Rachel?" And I'm just, all those counter pressures for 19 hours and whatnot. I mean, she did an amazing job. It's the greatest demonstration of human strength I've ever seen, is someone giving birth like that. but I was quite also fatigued. So be able to have someone to tap out to provide these different counter pressures and hold her just in a deep squat, or even the doula to help recognize the signs of transition and different stages. It was sure, certainly helpful for me.
There was an article that was kind of questioning whether or not occupational and physical therapists are needed on the maternal team, and which I could totally appreciate. I mean, we haven't been there all these years. Why now? But there's no argument against doula support. Would you agree?
I don't know. I haven't gone into much of that research in a while, so I haven't seen really what's out there.
Well, do you agree that doula support really is beneficial to anyone? You know, whether C-section, vaginal delivery, any experience.
For personal experience and just my personal narrative, yes. I mean, it was just a game changer. Our first one was 19 hours of labor, and our second one was only a few hours. So just while I think we got time, our doula came over because my wife labors at home mostly, and so she's about an 8 before she's gotten to the hospital for all three of our kids. And so our doula would be like, "It's probably time to get going," and she kept a calm and demeanor. And some of the choices that we had may not have been what she wanted, but we never felt judged. We never felt bad or guilty for what we chose, and we really appreciated that. But just recognizing those signs and like, oh, you better call the babysitter for your other kid. Let's start going this way. And she kept it calm and helped the process immensely.
Royce, when people ask, what do you do in a hospital room after someone gives birth? Can you kind of give us a day in the life of what that looks like?
Yeah, and it's always changing. That's the I use Lindsay Vestal has that kind of handout that I kind of use as a springboard to talk to moms about what kind of activities afterwards for core and pelvic floor return. But my first comment, I sit down with the mom after we do introductions and I say, what makes you nervous about going home? Like what is on your mind? What are you scared about? What have you heard about? Let's debunk some of the myths that you may have felt. You have older sisters that are telling you something that are making you nervous. What's on your mind? Let's talk about those things first. And it's fun to that helps me gauge the interest level. That helps me gauge what they've already learned about, what they've studied. And I can't remember one of the trainings somewhere. I'm trying to have more of a conversation with these new moms rather than a training. And if I have a good, productive conversation, I don't need to go through much of the pamphlet after that. So that's really where I start.
So when you say a good conversation, you mean that you're sitting down and you're just getting a sense of what they're nervous about when they think of going home.
Yeah.
And that gives you probably most of what you need to know.
Yep. So then it turns into the OT brain on, and the activity analysis comes piping through, and everyone has different concerns, there's some overarching themes, but everyone just has different feelings, and so that's what makes it fun.
In the article that I referred to, Dr. Christine Hinneberg, she's a family physician. She's writing about occupational and physical therapy that could potentially be offered to women in the hospital after birth. But when she interviews, I believe it's either a urogynecologist or a midwife in that article, the comment is that occupational therapy it's not even on their radar. And so if you can give me kind of a sense of like what you specifically mean when you say your OT brain turns on when you're thinking about activity analysis, what does that mean to the average person?
It's always a hard thing to explain, I guess. I wish I can articulate it better. But the examples I give, so one of the things that is fairly common with moms that come into outpatient afterwards, right, is some wrist pain. Like, and why do we have wrist pain? And I have had wrist pain when we give the stretches, that we have nerve glides, we give different things to help and strengthening techniques, but then we take it one step further. Why did you get this in the first place? The last one that came through with wrist pain is because she would pick up her car seat and her wrist would be an extreme extension, and she was having some ulnar nerve pain, and we kind of talked about how to stretch it. And I said, okay, show me how you're picking up. When does it hurt? And let's see the car seat. And we practiced it. And I said, well, what if we do it this way? Here's how we load the car seat. And we practiced the actual activities of what she's doing. And she came back 2 weeks later because we had Christmas in between. And I said, well, how you feeling this week? She's like, the pain's gone. It's gone. And so that activity analysis of taking it one step farther than just what with the pain, and just we start then going into why you got in the first place. So that's been the shock that I felt even just before working with women's health. I mean, just in general, that why we get certain infirmities, ailments is not talked about. We just treat the symptoms. I've had other conversations with someone else with carpal tunnel, and I said, okay, why'd you get carpal tunnel in the first place? And she's like, well, I've had physical therapy, I've had a carpal tunnel release, I've talked to my orthopedist, and no one's ever asked me why I got it in the first place. I'm like, well, why not? Like, what's the point of doing all these remedies and surgeries if we're not going to talk about why we got carpal tunnel in the first place? So that was probably a changing point in my career to really find the whys of what we do.
So let me ask you this. You're in the hospital room. Someone now is after a cesarean section. Unexpected. I don't know if you've run into this this situation before, but they were completely expecting to have a vaginal delivery. Goes to C-section. Now you're asking about these activities that in your mind could potentially lead to carpal tunnel. So you're already working backwards from those ailments, but what other ailments are you working backwards from?
Oh, that's a good question. And again, that's where that conversations help, right? Because that's where they start giving me the feedback. I mean, we're going to be talking about a lot of with us with the C-sections. There's the scar management too. That's a big concern that we get, and that's fun and outpatient to be able to do some scar massage to help to be able to alleviate that pain, and moms feel quite a bit better. But we talk about C-sections. I don't know. Those are my favorites to work with, actually. The ones that have a C-section that weren't planning on it, because that's just where there's just so much work and potential to be there. I just sit down and we talk about their feelings, and it's okay to feel what you're feeling, and don't feel guilty for this. And let's talk about this. Then we talk about postpartum depression and what that may be like, and have your safety plans set up. And we talk about the experiences that my wife and I had with some postpartum depression to help open it up, to allow that discussion for moms to talk about it. And right there, we kind of talk about, okay, who's your safety plan? You start to have these feelings. Who do you call? Who do you talk to? And just because you have certain feelings does not make you a bad mom. It's what happens. What can you do? So that's with C-sections I really hit up. I talk about postpartum depression with each of them, but with those unexpected C-sections, I make sure that's on my checklist in my brain of one of the first things I make sure to address. I hope that answers it some.
Well, Royce, let me ask you, I mean, I don't know as a physical therapist that postpartum depression, and this is a little bit embarrassing, I know now, but when I first started treating women after like unexpected C-section, I don't know that I ever talked really about mental health aspects. I think I might have thought about it, but kept it to myself. A lot of it was more, how are they moving, if they're protecting their incision. But it seems like you're like starting really with this conversation first and foremost. Like, how do you feel about having this surgery?
Yeah, I don't wait for them to bring it up. I bring it up right away. Even an outpatient, when they come in for the first time visit, if they come, I don't ask them if they've experienced postpartum depression. I just ask, how has postpartum depression affected you? And just let's talk about it. Let's not wait. Let's just help normalize it, because it's a feeling that we get, and let's start talking about it right away instead of trying to hide it and push it away.
Wait, Royce, That's your approach. Like, how has postpartum depression affected you? That's how you'll ask the question.
I do, yeah. Because I mean, it can affect you some, it can affect you a lot, but at least I ask. That's the way I ask it. Not have you experienced it, yes or no. It's not a closed-end question. I want to keep it open.
Okay. So you're in the room, you have this conversation. What are things that you do with a mom who just had a C-section? I want to also like talk about vaginal delivery, and definitely, I mean, you brought up hysterectomy. I had no idea that you're seeing like this variety of patients, these varieties of surgeries and procedures in the hospital, and then following up with them outpatient. And you're the follow-up therapist, is that right?
Yeah, yeah.
Okay. How are
Um,
you breathing right now? I mean, I'm just I'm thinking about like the volume of patients that you must be seeing. So this person has a C-section, you have this conversation. They trust you because you're sharing your own experience and your wife's experience. Then what do you do? What are you doing?
so we go over kind of just basic stuff with, how to, a common complaint we get in outpatient is constipation. So we talk about keeping water intake up and fiber and, just different positions on the toilet with the squatty potty and diaphragmatic breathing. And then just a couple basic stuff, so pelvic floor exercises. We practice diaphragmatic breathing. I've learned that a lot of new moms, even at that 4 week time, still do a lot of chest breathing. So we really focus on the diaphragmatic breathing and show them. I give them a TheraBand, just kind of basic back exercises, and then just other functional stuff along the way to keep them going. I get up and we go for a walk, and we talk about protecting the incision, and then we talk about posture and how we can change our posture and body mechanics and bed mobility, and our hospital currently does not offer abdominal binders, so we talk about how to get those and how to wear them properly, and and then we start taking our walk, and then we have just let the conversation go where it goes, and then just do the activity analysis along the way. It goes from getting in and out of a car to getting on off the toilet at home to how do I get on off my low couch, how do I sleep at night. There's just too many things to really talk about in my time that I have with them, so I let them drive the conversation as much as I can to address what's on their mind.
A lot of the feedback voice that I've gotten has been about therapy, just in general, OT, PT, but that to add us on the team, it would probably be too overwhelming. It sounds like the way that you're avoiding that is you're letting your patients lead the conversation. Do you do that in your practice in general?
Yeah, I mean that's how we stay client centered. Right? That's I'm not. There's just too many things to bring up, and that's what helps me. And there's so many different things I could talk about, and I don't want to overwhelm them. I don't want to be there for too long. So I mean, I with C sections, I see them the day after and the next day, and I say, after our conversations today, some ideas may pop up in your head. Write them down. Let's talk about them tomorrow as we get up and move around. So yeah, but my attitude is as well when I get in there because I knew this could be um, some hard ground to get into because even in the maternity ward, right, I'm the only male besides the OBs that pop in there, and I did not want to go in there saying I have this new way to provide services to in here, and I'm here to kind of trump what you're doing. I went in with the attitude as I'm here to augment what you're already doing so well. I'm here to support you. What can I do to help you out? And the nurses
Right.
have responded well to that sentiment of how, just getting people up and moving and helping them, and that's that's been a good response for them.
So, Royce, did you initially get pushback from nursing?
No, so how I approached it first, I approached the nursing manager. There was just a little bit of hesitancy about what I would be doing, so we had to kind of. I would have a chaperone every time I went into a room. Was how it would start. That was part of the agreement, and so um, that has changed a little bit now. Now if the partner is in there or family's in there, they let me go in by myself. But then I just put together a presentation, and I presented to all the OB nurses when they had some meeting one night, and got them fired up with it. They loved it and all wanted to come do therapy with me afterwards. And then, of course, going in, just breaking in, there's going to be some awkwardness, right? It's just how it is, getting to know nurses' names and how things are run and kind of their flow. And it it takes a little bit, but little by little, we keep it going. And we're always working to improve it. There's always more to do.
Royce, I have to ask you this. Do you think that your job has been a little bit more easier? I mean, you were working with a male OBGYN. Do you think that that has anything to do with how well your patients have kind of, accepted, hey, this is a male therapist in the room, or even the nurses? Do you think that has anything to do with it?
I don't know. But, I mean, getting in there has sure helped. There's been some resistance just being a male, and I get there's a gender barrier, right? But I really want to make sure that those who really want the services can have access to them. Right? I have these births. I probably talk to 4 to 6 moms a week. Right? We're a rural hospital, so we're not having a bunch come through. And I'd probably say of those 4 to 6, maybe 1 to 2 of those will actually come into outpatient because those are the ones that want it. Some don't care as much, but it's branched out to not just from the OB, but I'm talking to our urologist. I'm talking to pediatricians. I've had moms come in from pediatricians. I'm talking to, we have a new maternal, I don't know, women's health clinic kind of opened up an adjunct to the OB's office. So I'm getting referrals now kind of, and they're not flooding in, but one here, one there. They just help fill the schedule up. So it's just something I'm passionate about. So I talk to anyone who will listen to me about it. Again, I don't usually generate that small talk.
Royce, I have to say, I mean, I think working in a rural area, it opened my eyes tremendously. Like, I have to say this because we silo our profession and our therapists into either acute care or outpatient. What impact has it had on you to be able to see someone, recently after a hysterectomy, a C-section, vaginal delivery, but then also follow up with that same person within 4 weeks of their procedure? How's that impacted your practice?
I've gotten the feedback that it's nice to see familiar faces. That's something that they've really enjoyed, just to kind of get it going. We're still trying to figure out how to get to the prenatal population with that as well, because I'm not getting too many coming in before. A lot in my trainings would say, boy, I wish I would have known about you my 3rd trimester. I would have been there to see you then. So it's just that familiar face across the continuum of care. I mean, just working in rural, when I used to work more places, there's a handful of patients that I've seen in acute, in home health, in outpatient, and in skilled nursing. So you get quite that continuum of care through all the phases, and you start to make friends and get to know people. So that familiar face sure helps.
Do you think that eventually you would like to train more therapists? I mean, for this to be sustainable, right? You would need to.
Right.
You've already mentioned Lindsay Vestal, and I have to just kind of say, her work for me personally has been career changing. Like I don't think, apart from lymphedema therapy and even just acute care general practice, I don't think that I've appreciated occupational therapists more since I started to really take the time to learn what it is you do and learn how it fits so well, especially with maternal health. I mean, every activity that we're doing is so crucial to their identity, to the relationships that they're forming, the even the ability to communicate, their need for help. So much of it really has opened my eyes to knowing that there's just no real value to just providing access to just one discipline. And I've said this publicly before and I'll say it again. If there's a primary that's needed in the room, it's an occupational therapist that soon. especially if it's an unexpected delivery and there's so many activities that person has to adapt to in such a short time. I'm there in the hospital, in your hospital, Royce, about how long? 1 day, 2 days after delivery, even after vaginal delivery? What's the average length of stay?
For vaginal deliveries, once they hit that 24-hour mark, they're good to go home, and so they don't stick around for very long. The C sections, they'll get one more day, and
2 days then.
yeah. So that's changed from when we had ours, but they get them out quickly. So I don't get much time to work with them before they head on out.
So you get about one visit.
Yep, one visit for vaginals, two for C-section, and the one for hysterectomies too.
And one for a hysterectomy. And so, if someone wanted to learn and go through the path that you've taken, find Lindsay Vestal for sure. Find OTs in pelvic health. Sarah Lyon, I mean, she's another one. I mean, just her community that she's built through OT Potential. And so, all of these different avenues and just understand pelvic health in general. That's what you would recommend. Is that right? Someone take pelvic health courses. But my question to you is, in the acute care setting, how much of that are you bringing into the inpatient environment?
I'm not sure I understand the question.
When someone is going through pelvic health therapy courses,
Okay.
do you feel like it's is preparing them for the acuity of birth or pelvic surgery?
Yes, it is, and I don't know. I don't know if it's in the end of Lindsay's classes or some other class, or I don't know. I've listened to so many different things, but there's always that fear you just need to take one more class. And I've taken that advice to heart and trusted those who have gone before me that I don't need to take just one more class. I'm continually taking classes. This is pretty much all my continuing ed has been for the past 2 years, but I just start jumping in. I learn by doing, I learn by messing up. I mean, I trust my skills enough that I'm not going to be hurting a mother. So I get in there and just start going and I adjust and like, okay, that didn't work this time. Let's go this last time. And that's why I enjoy working so much more than the academic setting because can get in and just get going to work. That's my specialty, I guess.
Royce, I love that you said that. I honestly, and I'm guilty of that. I think I went after every certification that I could in my first few years of practice. And when I got to acute care and got on the maternity unit, I was convinced nothing had prepared me for it. I just needed to start practicing. And
Yeah.
especially, I didn't have a med surge, excuse me. I didn't have like a robust med surge background. That was probably 1 day every 5 weeks that I would see med surge patients, and it was always like I was starting all over again. And then when I started to treat, women after C-section, then honestly, I probably treated hysterectomy inpatient before we really got into C-section orders. That was still just like a shock. Like, okay, this is basic like surgical post-op care, but I didn't feel that really anything prepared me for it other than to practice, right?
Yeah. Yeah, and I've learned that. I mean, I served a mission for the Church of Jesus Christ of Latter-day Saints, and I was in Spain, and I studied Spanish to my heart's content. I was just living daylights out of it, but I learned until I went out and just try to speak Spanish the best that I can. I could study until I was blue in the face, and it wouldn't do me anything. So that's really where I learned some of those hard work and just talking to everybody tactics, just getting out there, making the mistakes, and I learned so much faster from them. So that's where I love
Right.
all of that from.
If there are men who want to treat this population but they're hesitant, what's some advice? What's some recommendations that you would give them, even beside the courses? I know that we can name a ton of courses. I can now, but just what really is the hang up with getting more therapists? First of all, in general, like that's really what I'm up against. We're seeing what 1.2 million C sections a year, at least performed in the United States. hysterectomies again, what are we at, 500,000? I mean, there's no way that our two professions can't be of some value. I'm a strong believer in that. What's your advice for just getting started in the inpatient setting and offering our services this on?
So it was some advice just to, if you're already in the inpatient setting, start applying, pelvic floor stuff to anyone. Like I'll work with an 85-year-old just this morning with pneumonia, right? We can work on urinary incontinence, bowel management. Like there's things we can work on. Like I get 45-year-old with small bowel obstruction, right? So we talk about bowel management, right? So that's a fun place to start. And then nurses start hearing what you're doing, and they start bringing that up when you talk to them. So it's where you work. Just start asking people about it. I mean, I'm still shocked that OT's, at least my OT school, is still not teaching pelvic floor. But if OTs claim to be the ADL experts, I don't know how we can be without studying this more so. But this affects a lot more than just the maternity population. So that's where I started too, is just talking with anyone and everyone about it.
Do you identify your practice as pelvic health, pelvic floor therapy?
Yes, because that rings as well. That's the phrase that people recognize. So I will bring that up. We're a little bit different in the fact that because of the gender barrier, I don't do any internal work or external observations. I've had success just coaching moms as well and we have different handouts to say this is something to go try at home, go try it yourself, use with your partner to help you with it, and we've had success that way. And I don't want any mom to not come in because she may feel embarrassed or apprehensive about it, and so that's how we set up this practice here.
The gender barrier is a big one. I can appreciate that. In terms of just the timing that you're treating these moms, I would argue that you're doing so much work upstream in a preventative way. Would you agree with that?
I'd like to think that. I mean, that's what I'm working for. I'm trying to get more preventative work done, and now that I'm starting to have more moms come in their 40s and their 50s who didn't do anything in their 20s and 30s, I give that advice to the moms who are having kids to say, this is what's potential in the future. Like, I'm not trying to scare you. I'm just trying to give reality checks. Let's just make sure we do something instead of just letting it slide. So
What
we're
kind of
trying.
things are those that do you just at least like bring to their attention? I don't think that you're catastrophizing things at all. I mean, to be honest with you, I think that people, the amount of women that would get angry and say, why didn't anyone tell me? That was overwhelming for me. I reached a point in my career where I couldn't treat as a pelvic health therapist in the traditional sense. And so a lot of the practice that I learned and skills that I learned in my pelvic health courses, I started to focus those on, like you are saying, to the inpatient population and to that population within the first 6 weeks. Because I figured if I could treat more individuals, before their tissues healed in a non-ideal way, I felt like I was doing more preventative work. And so
Yeah.
my thanks to you for saying that and telling them about what to expect is just beyond, really, is beyond, it's over the moon. But I wanted specifically for the audience sake, what are some things that you talk to moms about early on after birth, now that you're seeing populations 40 years old, 50 years old come in for pelvic floor therapy?
Yeah. So I start to relate pelvic and bowel. We say pelvic. Most moms think urinary, so just pelvic health in general. Core and posture is a big one. Like we got moms starting to get kyphotic, and we talk about how normal it is, and then this now starting to see hysterectomies. I see that hysterectomies so far have dealt with some pelvic pain in the past, and we start talking about what you may be experiencing. You see that relief in their face that someone's talking about it finally with them. And so, again, hysterectomies are new. It was it was a Monday where I got the official standing order for all hysterectomies, and so I started announcing 3 this week, and just those conversations, and those moms are fully on board with coming in and doing some therapy. Like, they're more so than the ones that just gave birth. They're just like, yes, I have felt this. I have painful intercourse. I have a hard time emptying my bowels, like emptying my bladder. Like, this is something that I've wanted to work on for a while, and I've had the hysterectomy to help get some pain, but I'm going to come do some therapy with you. So,
Wait a second. So this past Monday, January 29th, you just got standing orders for hysterectomy?
yeah, yep,
This is so cool. Okay. So you just got orders this past Monday. That's 2 days ago, Royce.
yeah. Yeah, that's
And you
it's
already saw 3 women in the hospital after hysterectomy.
yeah. It's been, I don't know. It's just, this is continually changing and emerging. One of the thoughts that I love, one of my sports psychology books talked about, I don't know what the gold standard is. I don't know what my goals are, so I'm always going up. I love process goals more than outcome goals. My process goals are to keep this going, and I don't know where it's going. I don't have some finite point that I'm trying to get to. So it's just always refining.
More conversations like this, please. I mean, I think if anyone's joining us live, put in the chat where you hope Royce takes his practice. Do you see him teaching at least as an adjunct professor? I didn't even ask you, Royce. Do you do any adjunct guest lectures, anything for OT students to just learn about what you're doing?
I do not currently. I mean, the closest
Okay.
university is 2.5 hours away.
I would love anyone who's joining with us, or I mean, even later on, leave a comment. What do you think about this video, this interview, this conversation? Do you see Royce Porter? Because I see amazing things. I see the whole state of Utah and every hospital that's delivering babies starting to look really closely at the rehabilitation and the experience that people are having after birth, after surgery. What you just told me, Royce, and I want to make sure that I'm repeating this correctly. Women after hysterectomy, they've more likely been suffering from some ailment before their surgery. And you've seen more excitement just in the 3 patients that you treated this week than you usually do with moms after birth. Is that right?
Correct. First time moms are a little ignorant of what's going to be happening, even though I try to give warnings. Second and third time moms may not have it quite the issue yet, but this morning I also talked to a 41-year-old mom, and she was fully on board. Like, she just gave birth to her kid 12 years after her last one. But yes, the ones that are a little bit more mature are, it's ringing home more so to them.
Royce, if there are therapists in Utah who don't yet have their program up and running, there's a few that we trained to start services in their hospitals, and this is just going to prompt me to kind of circle back. My big question for you is, kind of as we're wrapping up, would you be willing, if not students, to teach other therapists what you're doing? And I kind of chuckle because I know you have 4 other therapists that you're working with who have not been kind of like gung ho, but there's one PT.
Yeah.
If there are therapists in other hospitals in Utah, you know the laws of that state. You kind of know the practice. I'm thinking more state practice act. I don't know much about OT practice and direct access. I know some states have it, some states don't. So that could be another conversation for another time. But do you feel like you're at this point in your career where you feel comfortable teaching while you're on the journey before you reach the destination of whatever that is?
Yeah, I love teaching. I wish we'd have more students come this way. It's the ruralness is hard, but I love teaching and training, and I mean, it's another passion of mine. And that's an opportunity. I wish I had more opportunities for that, to be honest. So the answer is yes.
What about the ruralness? I'm curious because I wasn't probably quite as rural as you, but are you familiar with Cullowhee, North Carolina?
No.
Cullowhee, Asheville, Smoky Mountains, very rural area. That's where I completed my doctorate in PT. But when it comes to just rural healthcare in general, I think that you have to be prepared to see anyone who walks through the door. Would you agree?
Yeah, yeah. Sorry, I don't mean to laugh, but that is our
The
job.
man who's treated in what, like six different settings, I think you said at the beginning of this interview.
Well, it's just so many different variety, right? It's even today, I've seen the hysterectomies, I've seen pneumonias, I've seen joint replacements, I've seen concussions today, I've seen autism today. I mean, I've seen it all.
We need more people like you, Royce. I'm going to share with you some of the comments. I'm not sure if you can see on your end, but Gabrielle Billy, Gabrielle, I hope I'm pronouncing your name correctly. As an OTD student, I'm going to read right from what her comment was. I would love to see you teaching or even taking a capstone student because it can be so hard to find OTs who are doing all the great things that you are doing in this emerging field. Also, you seem to have a great way of making OT and maternal health make sense.
Huh. Thank
Pretty
you.
awesome comment.
Yeah, it is. I appreciate it.
Yeah. And she's actually from Atlanta, huge city, and still
Yeah.
struggling to find OTs of pelvic health. So, rural area, I would say that's probably the best field work opportunity for a student because you have to be prepared. You're probably less likely to be paired with a specialist who's only seeing, maybe a very niche population. You have to be prepared to see everything. You saw someone with autism today, someone with pneumonia. You're seeing small bowel obstruction. You're treating women after C-section, vaginal delivery, and hysterectomy during their hospital stay. You're a male OT, and that doesn't seem to be much of a barrier from what I've heard. I've heard probably all the good things. You haven't told me too much of the negative experiences, but overall, the nurses, the physicians, the patients are all on board and just immensely grateful for your services. Is that right?
Yes, yes, it is. Again, there have been some barriers, and especially being the only OT surrounded by PTs. But it's I love knocking down barriers, so it's it just gives me drive. So
Awesome.
frustrating.
Well, I know you said you don't have many goals. I'm going to give a few more comments to just kind of just from people who are watching and who joined us tonight. I think it's just important that you know what impact that you're making. There's a person joining us on Facebook says, Royce, I hope you continue to feel gratified as you empower women and help them avoid issues that they would otherwise encounter. Thank you for all that you're doing. There were so many comments at the beginning about your approach to postpartum depression. I mean, that completely just that helps me personally because I think that there's too much rooms or doors that are closed when that question is asked close ended. Like, are you experiencing postpartum depression? Yes or no? That's a closed ended question. And you're not leaving that. You're asking it in such an open ended way. And so I wanted to just give you feedback on that. That's been incredibly impactful. And so if you're joining us kind of midway and you didn't get that first part of this conversation, Royce, the pearls that you dropped tonight, how can people at least just connect with you if they have questions or just wondering how to get started? What can you leave people with?
Some contact info you're saying to reach out, or
Even if it's your hospital setting, if it's if it's just if it's through social media, whatever you're comfortable with, people would love to just know more.
so social media. I'm on pretty much just Facebook for Royce Porter. Um,
I tried to look you up on LinkedIn. Actually, are you on LinkedIn as well?
I think so, but not actively. I
I would fire that up. LinkedIn, a lot of people just think it's like an online resume. Royce has probably gotten me more attention than Facebook, Instagram, even Twitter put together. It's
okay.
connected me with more. And I'll tell you this for you if you want to really reach students, universities, opportunities to just even guest lecture, provide a 1 hour or even like a webinar, online Q&A, or even reach administrators, physicians. LinkedIn is a place to be.
Okay, I'll have to. I initially got started when
Yeah.
first trying to get through jobs, but I haven't looked at it really since.
Yeah. On all your free time, of course, Royce.
Yeah, of course. There's plenty, but anyone's more than welcome to reach out. I mean, even in this group, you can find myself as a member of this group, so you can find myself in there. But I've used that. I mean, another one I think is listen tonight. Jessica Lynn. I think I got her from one of Lindsay's Empower Hours, and she put her contact info out there, and she replies back to me, and she's a great resource. So, I mean, because I'm the only one doing this out here, I have to rely on people like yourself to really be able to reach out to and get feedback because I don't get any feedback here. So, if I can be
Amazing. You definitely have a network. I have to shout out the OB PTOT Facebook group. Are you a part of them as well,
yeah,
Royce? Okay.
yep,
Introduce yourself. Just drop your information. This video, it should be live, recorded, accessible for people to watch later. But we love to follow your progress. We love to follow your work. I said this and I'll close with this, Royce. There's so few of us, and you're encountering this. You're the only OT with four other PTs. Is that right?
5.
Five other PTs. You're the only OT. And so you're the only OT and you're the only therapist who's treating this population. And in a rural setting, do you know approximately how many births there are, even annually at your hospital?
Just with this one therapist, it's 4 to 6 a week. I mean, OB. The other OB is not quite as on board yet, so it's going to be, I'll say 250 out of 250 to 500, I guess, that are happening.
Yeah, really interesting. The person who inspired me, her name is Dr. Ann Krogan. She's over the OB PTOT Facebook group. And at the time that she gave her talk at a national conference in 2020, her hospital was seeing about 90 births a year. So you're well beyond that, right?
Yeah.
And so, kind of my interest with you is that yes, you're a male therapist. We don't often have even just the honor of just even seeing enough of you in the rooms, treating this population. But just throughout acute care, we don't have enough therapists who are available to treat the volume that we're seeing. What 3 million births are occurring in a year, every
Yeah.
year in the United States, and so we tag team PT and OT on knee replacements and hip replacements in most of our settings. That's not maybe the case for everyone. But when it comes to cesarean section, where there's so much of a demand on that person, depending on their situation too, that person could be a single mom, that person could have all the support. Maybe husband is deployed overseas. Maybe there's multiple children at home. All of this stuff that we know is going on. To start your session with a conversation that wraps care around that individual's particular circumstance is just phenomenal. But now I would encourage you as we end here, Royce, is to take every opportunity to just talk about what you're doing to people. Cases that you see, cases that may look like a post-op ileus or bowel obstruction case on another floor, where a mom after C-section is struggling, and just normalize the conversation of our presence in the rooms. I think that I want to demystify it. I want to take the mystery out of it. And I want more people to hear your story of just treating this population like they would anyone else. Because the more that we include pregnant individuals and women after birth in our care, the more that we can really address postpartum depression head on and not talk about it in a closet, right?
Yeah. Agreed. Agreed.
Royce, it's been a pleasure speaking with you tonight. Thank you so much for
Yeah.
everything, for reaching out to me a year ago, to getting on this interview with me. I can't thank you enough.
Well, I really appreciate it. I guess I don't have much interaction with others who are in this area or other OTs or therapists. So it's good to see more out there. I guess I know they're out there. It's just I don't get access to that.
They're out there, and they couldn't be more supportive of your work. Same here.
Well, I appreciate it a
Thanks,
lot.
Royce. We'll talk soon.
Okay.
Bye.
Bye.